Two, one. Please start, sir.
Yeah, a very good evening and very welcome in this the session of Nubika Clinical Conversation of the month of this April. And very warm welcome on behalf of Team BR Oncology, myself Sagnik, with me, my colleague Arnav Chakravarti also. And in this session, we are with Doctor with us. First of all, we're going to the Doctor Madhuchanda Kaur Madam is a very most senior medical oncologist from PRDS Hospital, Kolkata, with her rich exposure and expertise in medical oncology and different segments of oncology segment. And with that also, we are going to invite Dr. Suman Mayur, who is a medical oncologist from the SGCR Hospital, Kolkata. So we're going for the first session, welcoming both of the doctors. Welcome, ma'am, and welcome, sir. So in our first session, we are going to invite Dr. Suman Mayur sir for his session on this reaching new heights in the MHSPC care. So
No,
I think,
no. I was
okay,
already mentioned that I will be first
okay, no issue,
because I've got
no issue.
another meeting.
Okay. Then I should invite Dr. Madhuchandakar madam to start for his for her session first. Welcome, ma'am.
Good evening. Can you share the slides?
Yes. Just give me a minute, ma'am. Is it visible, ma'am?
Yes.
Okay. Welcome, ma'am.
So you want the video on, but remember
Uh,
that
uh,
network is an issue.
Yeah. I already mentioned, ma'am, just for as per your convenience, for first few minutes it can be, then
Okay.
you can switch.
Okay.
Yeah, ma'am. Yeah. Thank you very much, ma'am.
Good
Very,
evening,
very well welcome.
colleagues, and good evening, the organizers. Today's topic is something very, very interesting, that is advancing the treatment horizons of metastatic hormone sensitive prostate cancer. Now, we all know that there are many patients in prostate cancer who have got metastatic hormone sensitive disease where we might prefer not to use chemotherapy. So, is there any evidence that we'll do well with these patients without chemotherapy? And that is the discussion today, whether darolutamide usage can do away with chemotherapy in certain fraction of patients, like those with many comorbidities, those who are frail, etc. and etc. So this is the evidence from ARA-NOTE study. Next. Disclosure, I have nothing to disclose.
Okay, then going for the next slide, ma'am.
So if you look into the journey of metastatic hormone sensitive prostate cancer, how it has evolved to combine ADT. Please, somebody is talking. How can I talk? Please mute yourself. Otherwise, I'm only hearing you talk. So this is the journey of how the care of metastatic hormone sensitive prostate cancer has evolved. And we all know that we were comfortable using docetaxel, and we commonly use docetaxel in certain criteria of patients, except those with low volume disease. Now, there has been the charted trial with ADT and docetaxel as early as in 2014, followed by Stampede in 2015, Latitude in 2017 with ADT, Stampede, another arm with abiraterone and ADT, enzalutamide in 2019, Titan with apalutamide, again Enzamet trial in 2021. Then that very important trial of darolutamide, ADT, and docetaxel, 2022 ARASENS peace trial that reiterate the use of triple therapy. So in 2024, this ARANOTE trial showed that darolutamide plus ADT is an important option, and we can use this in some fraction of patients where the clinician is comfortable to do away with chemotherapy. And we must remember that despite all these types of combinations, a large proportion of patients with metastatic hormone-sensitive prostate cancer will ultimately progress to mCRPC when the outcome will be quite bad. And this will happen within, say, 3 to 5 years. Next. So an unmet medical need remains for an efficacious treatment that offers a differentiated and improved safety profile. I think we must keep a very important note on safety profile for patients with MHSPC without adding significant toxicities and with a low drug-drug interaction potential. So this is the main spirit of the ARASENS study, which already has shown beneficial efficacy and safety in these subsets of patients. So this has received the approval of Indian regulatory body in 2023. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in MHSPC, as demonstrated in this global phase 3 ARANOTE trial, where there were many Indian patients as well. With ARANOTE data, darolutamide has shown to be a potential game changer, if you can say, in the treatment paradigm, as now it would be the only ARI that can be used along with chemotherapy or even without chemotherapy. And we know that there are two types of drugs. Abiraterone is an inhibitor, and these are the enzyme inhibitors. So different way of action of enzalutamide, apalutamide, darolutamide compared to abiraterone, which is an inhibitor of the receptor. Next. So we all know that we would prefer the triple therapy in metastatic hormone-sensitive prostate cancer unless they are very low-risk patients, as documented in the ARASENS trial, where favorable efficacy and safety was observed. Whereas ARANOTE has been designed to evaluate doublet therapy as a treatment option without the use of docetaxel. So I think in India especially, we get many patients who are quite elderly, quite frail, many comorbidities like diabetes, etc., and many patients who stay far off. So coming to take the chemotherapy may be a challenge, and their frailty does not permit the use of chemotherapy. So here, if we can have a doublet which can be taken at his native place, and that would be a brilliant option for these patients. Next. So the study design was histologically or cytologically confirmed adenosine of the prostate with ECOG performance anywhere between 0 to 2, and the randomization was 2:1, where darolutamide 600 milligram BD with ADT or placebo with ADT. Now, there were some stratification factors like visceral metastasis as opined by the central review, then any prior local therapy, yes or no. So these were the two stratifications. What was the primary endpoint? Of course, the progression-free survival, but there were important secondary endpoints as well, like the OS, like time to initiation of subsequent antineoplastic therapy, time to progression to CRPC, time to PSA progression, that's a biochemical progression. What are the rates of undetectable PSA? That means very deep response of PSA. Time to pain progression, safety. So all these were important secondary endpoints. And there were also some pre-specified endpoints like PFS2. Nowadays, this is very common, as you know. Time to the deterioration of the fact P, quality of life, time to first prostate cancer related invasive procedure. So all these are pre-specified endpoints, and this is an open label daralutamide study. 100% crossover to open label daralutamide was possible. Data cutoff was in 2024 June. Median follow-up of both the groups was more than 2 years. Next. These are all quite well balanced as far as age, race, region, whether Asian, American, Latin American, European. ECOG PS 0 and 1 to 2 was quite similar. Gleason score similar. Serum PSA median range was also quite at par. Metastases at initial diagnosis, de novo, and recurrence was also quite similar in both arms. Visceral metastasis also was more in this, slightly more in this daralutamide arm, and prior local therapy was well balanced. So this is the slide showing that the data and the trial was very well balanced trial. Next. So these were all the countries: APAC region, China, India, Taiwan, Australia, New Zealand. So the Asia Pacific region was quite extensive. Next. Can you go back to the previous slide? So 204 patients, Asia, Latin America 191, Europe and rest of the world 274. So Asian was 30%, and I think North America, Europe around 39, 40%. Next. So this is the reduced risk of progression or death, that is reduced by nearly 46% in the daralutamide arm versus the placebo arm. And hazard ratio, as you can see, is quite significant statistically. Median follow-up, as I mentioned, was around 2 years, or more than 2 years actually. Primary endpoint was progression-free survival. Next. Well, this was consistent in the different groups, both in the high risk as well in the low risk groups. So the volume of disease, the burden of disease did not actually significantly alter the outcome with daralutamide ADT as compared to placebo ADT. So across all groups, you can see that it is beneficial, as you can see from this hazard ratio, favorable, all favors daralutamide, all groups. Next. So this is a, can you go back? This is a red line that really shows you that whether it is a high volume disease or it is a low volume disease, we usually feel that, okay, ADT alone can be sufficient for low volume disease, but this shows that even in low volume disease, this combination doublet is doing very well. Next. So across all the endpoints that I mentioned, primary was PFS, secondary is OS, time to MCRPC, time to PSA progression, time to initiation of subsequent systemic therapy, say chemotherapy, time to pain progression. Again, in this, you can see that all these were on the left-hand side. So across all group, they benefited. The OS is immature, so patients will be followed for survival. And all remaining per protocol placebo patients suffered a crossover when they were progressing. Next. So this makes the data all the more strong. So this is a curve showing that this combination delays time to CRPC, time to pain progression. I think CRPC, once it is progressing to CRPC, the outcome of all these patients becomes very much challenging, and we all have faced it in our clinical practice. The journey becomes very difficult. So our main aim should be to initiate the doublet as early as possible to prevent progression to CRPC, and if needed, we give the triplet with chemotherapy as well. Okay. Delays in time to pain progression can be of high importance to patients and have not been demonstrated with other AR inhibitors today. So as pain is important for quality of life, this is an important parameter that we must note in this study. Next. These PSA responses have been deep and durable. As I mentioned, that less than 0.2 nanogram per ml was also achieved in a good percentage of patients. If you compare it with placebo, you can see that very high difference. Less than 20% in placebo, more than 60% in the doublet. And time to PSA progression, as you can see, that the curves are separated so early in this population. So 63% of patients in darolutamide doublet attained PSA less than 0.2, and this represented 69% improvement in time to PSA progression in the doublet as compared to placebo alone. Next. So this is both high volume and low volume, where you achieve a PSA response that is very, very deep, less than 2 nanogram, less than 0.2 nanogram. It starts 24 weeks. Then, of course, 36, 48, they have measured. So 24 weeks, it really starts all the tricks in both high and low volume disease. Next. So the journey in the life-prolonging anti-cancer therapy, patients with subsequent life-prolonging systemic antineoplastic therapy. If you have darolutamide tablet, this is 32.5 as compared to placebo, and ADT where it is 42.5. So that is also very satisfying for these frail and elderly patients with a lot of comorbidity. They do not want to take the subsequent anti-cancer therapy, so they want to avoid it as much as possible or to delay it as further as possible. Next. And all these adverse events, those who have used darolutamide, we know that it is a really well-tolerated drug. We are very satisfied with this usage of this drug. The serious AE has been quite at par with the placebo, 23 as compared to placebo, which is also 23 out of the 445 in darolutamide and 221 in placebo group. So this is really encouraging. The median treatment duration was 2 years in darolutamide arm versus 17 months in the placebo arm. The safety data in the aeronaut was independent, very, very important, independent of the biochemical response. That is the PSA response. So favorable tolerability was seen. We have already seen in previous Aramis trial, and again in this ARASENS trial, it is reiterated. Permanent discontinuation, you can see 6% in the darolutamide data. Next. And common AEs were quite low in both the arms and similar. We know that ADT itself has got many adverse events like fatigue, hot flash. Add to that darolutamide, of course, fatigue will be a bit more. And as you can see from the red line, that fatigue is 5.6 compared to 8.1 in the placebo. So really, in this data, no additional fatigue with the combination arm. But of course, we find fatigue is a problem with all these ARI. Then back pain, constipation, arthralgia, some SGOT, SGOT rise, bone pain. So all these are very manageable side effects. And in general, darolutamide usage, patients have a very fair quality of life. Next. Adverse events commonly associated with ARIs, we have already mentioned. I think this is same repetition. But we must be very careful. There are some which cause more CNS destruction, CNS penetration, like the enzalutamide, which has got mental impairment. Darolutamide is free from that. Coronary artery disease also, we must be careful. We must keep this in our mind. And drug-drug interaction is very important because all these patients have got a lot of co-prescriptions. So our comorbidities can really guide us in the choice of ARIs. Next. So as I mentioned, FACT-P score, which impacts the quality of life, which shows the impact on quality of life, overall well-being, pain progression. All these have shown that this is a drug that has a very positive impact on the FACT-P total score. Next. So this is quite the same. Social, family well-being, functional well-being, all have been. The urinary symptoms as well, they are very important, especially those who are quite agile and those who are having office practice, those who go to do their work outside. Urinary symptoms do affect their quality of life. So this shows that there is a very meaningful impact of the tablet on the different parameters of quality of life, like functional well-being, social well-being. Next. So darolutamide with ADT without docetaxel. Docetaxel can be avoided, and we all know that in elderly they have sometimes very severe and sometimes manageable but very meaningful adverse events that can frighten the patient and their family. So this should become an additional standard of care for those patients who are having metastatic hormone sensitive prostate cancer, as they significantly improves the progression-free survival. So this doublet is another option in these patients, whether it's low volume disease or high volume disease. They did have positive impact in both. Even the secondary endpoints like overall survival, pain progression, progression to CRPC, all these were positively impacted. The PSA response was deep regardless of the baseline PSA. Darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in certain parameters, of which I think very important is pain progression, as pain has got a very visible impact on the patient and their family members. Nobody wants to see their patient writhing in pain. Overall well-being is also important because these are patients who want to be in the society in a meaningful way, contribute to their family, have an overall functional well-being. And as I mentioned, urinary symptoms can be very embarrassing. So if this tablet has favorable impact on all these parameters, this is an option and standard of care for many subsets of our patients. And what is very important is a favorable safety profile because these patients can have stroke, previous history of cardiovascular events, history of CNS mental impairment. So all these are unaffected by darolutamide, whereas the other ARIs have got a lot of drug-drug interaction as well. So this should become as a doublet without docetaxel an additional standard of care for certain subsets of metastatic hormone-sensitive prostate cancer. The clinician is the best judge that where to use this particular doublet and avoid the chemotherapy. Especially in low volume disease, we would be very much inclined in frail and elderly patients with a lot of comorbidities. I think by now we are all convinced that this doublet has a very meaningful impact in many subsets of our patients who come with hormone sensitive prostate cancer that has already metastasized. Next. I think we had a wonderful exposition of this trial and we are convinced with the outcome, the OS, PFS, all these have shown wonderful impact as compared to the placebo. So any questions from the audience, I'm willing to answer because I've got another session after this. Thank you, the organizers, for giving me this opportunity to share some of my views on a very rising and important cancer in our day-to-day practice, that is the prostate cancer.
Thank you, ma'am. Thank you very much for your very nice presentation. And with all your permission, I will want to go for our, if there is no questions from the audience, so we can go for the next session with Dr. Suman Mayu. So
Okay,
I think
can I
Dr.
be excused? Can I be excused?
Yeah,
I'm
yeah,
done. I'm done.
yeah,
Okay, thank
yeah,
you.
yeah. Your session
Over
is
to
done, ma'am.
Shuman.
Yeah,
Over
yeah.
to Shuman.
Thank you, with your permission. Thank you. So is Dr. Suman sir is there?
Yes, good evening. Good evening.
Yeah, good evening, sir.
First of all, thank you, madam, for such a nice talk about the study of darolutamide in form of ARANOTE. I'll deliver my speech on ARASENS trial. I'm going to start now. Thank you, Bar, for organizing such a nice platform for talking. I'm sharing my screen. Is my screen visible?
Yeah, yeah, sir. It's your screen is visible. Sir, can you please on your cam for a few minutes of
Yes,
this
yes.
session, sir?
Turning on
Yeah,
my camera.
yeah.
Yes.
Thank you, sir.
This is not. Okay, so The name of my topic is Reaching New Heights in Metastatic Hormone-Sensitive Prostate Cancer Care. So as we know that the timeline of aggravation of prostate cancer by its nature is to start with a localized disease and to end in a metastatic castration-resistant prostate cancer, and then to cause a terminal disease and death. So all our endeavor should be directed to prevent the metastatic CRPC as good and as deeply as possible, and we should delay it indefinitely to have
So,
the best of the outcomes. Yes,
so
yes.
sorry to interrupt, sir.
Uh,
Can you please on your cam, sir? Your screen is very much
oh,
visible.
no,
Your
actually, I'm inside my
okay,
car,
okay, okay, okay,
so I have
okay.
turned on the lights of my camera. Am I visible now?
No, not sir. Okay, no issue. You can carry
No,
on,
no,
sir.
no. Okay.
Yeah, yeah, it's okay. It's okay. It's okay, sir.
It's okay, now. It's okay.
Now okay, now okay, now okay, sir.
Okay. So as I was saying that we need to delay the uh, metastatic castration-resistant status as far as possible, and we need to treat the earlier stages very keenly. And I think most of the patients present with a de novo or newly diagnosed metastatic hormone-sensitive prostate cancer. And there might be some primary progressive hormone sensitive prostate cancer who were initially localized, but before achieving a meaningful testosterone response, that means castration level testosterone, they can progress to become a metastatic disease. So as we know that if the patient reaches the state of metastatic castration-resistant prostate cancer, the OS improvement is of only about a few months, a couple of months, 2.5 to 4.5 months. So we need to treat the metastatic hormone-sensitive prostate cancer so well that we can delay all these things. So as we know, the trials for achieving a good response with metastatic hormone-sensitive prostate cancer started as back as early 2000s, and the results came in the years between 2013 to 2020s. And initially, as it was known that suppressing the hormone will help to reach a very good PSA response, but the researchers were in search of another drug in form of a chemotherapy or in any other form that will help to have a good radiological and biochemical response in the disease. The first of them was the CHARTED trial, published in 2015, that proved that addition of docetaxel in along with ADT will have a good hazard ratio in form of OS and PFS. And after that, the STAMPEDE trials, which initially had many arms, and the 2017 update of the STAMPEDE trial, which allowed abiraterone acetate to be added with ADT. So docetaxel and abiraterone acetate both showed a good response through STAMPEDE trial. As we see that in STAMPEDE trial, the overall survival and failure-free survival both were statistically significant, and addition of docetaxel was very meaningful. And here, through CHARTED and STAMPEDE trial, as we have defined, that the prostate cancers can be bulky with more than 4 bone metastasis, more than 1 extraaxial metastasis or visceral metastasis. They actually fare very badly with any treatment. And this subgroup actually do not fare very well in form of PFS or OS with any of the treatment previously given. But addition of docetaxel could have helped to this subgroup of the patient to have a better OS. In STAMPEDE trial, radiotherapy was also tried in metastatic disease, but it was seen that in non-bulky disease or patients who have less burden of the disease had a good outcome with the addition of radiotherapy. We can see with more than 4 bone metastasis, there was actually no OS or PFS benefit or FFS benefit in prostate cancer. So after the usage of docetaxel, after we have done with the docetaxel, we have explored the effectiveness of enzyme inhibitor in form of abiraterone acetate. We have introduced many drugs in androgen receptor pathway inhibitors in form of enzalutamide, apalutamide, and recently darolutamide. So with all this data, that the trials for enzalutamide in form of ARCHES or Enzamate, the trials for apalutamide in form of Titan, and all the others, abiraterone acetate in form of STAMPEDE and Latitude trial, we can see that the hazard ratio was in the bracket of 0.65 to 0.7, which was obviously very promising and the statistically significant, and all these drugs were actually comparable until the peace protocol, which introduced triple drug regimen. As I've said, that in CHAARTED trial, addition of docetaxel, especially in high volume disease, had a very meaningful outcome, and the median WES was very high, and as a ratio was 0.63. It was almost 37% extra benefit with the usage of docetaxel, and the statistical benefit was highly significant. Improvement of voice was almost 16.8 months. But in low volume disease, addition of the chemotherapy actually doesn't do any good in form of voice benefit. In Latitude trial, in high-risk hormone-sensitive metastatic prostate cancer, we can see that abiraterone acetate could be another option. It was first to show that the hormonal treatment can be effective. But as we know that this is a CYP enzyme inhibitor, we need to add prednisolone to abiraterone acetate, and its mineralocorticoid-related adverse reactions might be cumbersome to handle in some patients, especially elderly patients who are prone to have hypertension or who are having already a prior cardiovascular risk of disease. And we can see that abiraterone acetate had very high incidence of hypertension, hypokalemia, and cardiac disorders. In Titan trial, the drug apalutamide, which is an androgen receptor pathway inhibitor or signal inhibitor, had a good PFS and OS benefit. And the hazard ratio for the PFS was very impressive. It was 0.48 with a p-value of less than 0.001, which was statistically highly significant. And we can see that this drug excel to have a meaningful response in both high volume and low volume disease. And statistically, in low volume disease, it has a better hazard ratio to have 0.36 value. So apalutamide became a very good drug to start with. In Enzamate trial, we can see that enzalutamide along with ADT showed a good hazard ratio in form of clinical progression-free survival, which was in form of 0.4, and it was again statistically very significant. And in subgroup analysis, we can see that it was actually had a meaningful benefit of OS in low volume disease. The p-value for low volume disease was significant, but it was not that much significant. It was 0.14 in high volume disease. So in high volume disease, we cannot use enzalutamide as a drug of choice. Now, as the advent of PEACE-1 study, we could have used the triple drug regimen. We could have used all these drugs together, an ADT, chemotherapy, along with one androgen receptor pathway inhibitor or enzyme inhibitor. In PEACE-1 study, they have added abiraterone and prednisolone in the comparator arm, in the other arm. Here they have taken de novo metastatic diseases only who didn't have any prior chemotherapy. Also, this trial randomized the patient who had ADT for less than 3 months priorly. So these are the patients who are newly diagnosed metastatic disease, especially with the high disease burden. They have taken both high and low volume disease burden, but especially for the high disease burden, this trial was proved to be very effective. They have also given radiotherapy, and they have randomized it in another arm. So in one arm, they have used ADT and docetaxel, which was the standard of care at the time. And in some patients, they have added radiotherapy. And in the other arm, they have used abiraterone and prednisolone along with the ADT and docetaxel. And they have also used in arm D radiotherapy in some patients. So in PEACE-1 study, we can see that in high volume patients, the hazard ratio was of survival was very impressive. It was 0.72, statistically significant, and it had sustained response for a very longer time. For low volume disease, we can see that the addition of the third drug didn't prove to be very meaningful, with the hazard ratio being 0.83, which was not statistically significant. So we can say that in high volume disease, the triple drug regimen actually is very much effective if we can add up do abiraterone along with ADT and docetaxel. But we should mention that again, the abiraterone has some intrinsic complications, especially in the elderly patients who have high risk of heart failure or is having an uncontrolled hyperglycemia, where we cannot really use prednisolone for a very long time. So there was a scope of introducing another drug instead of abiraterone acetate, where the same results could have been obtained. In this regard, ARASENS study emerged to be a very good option. Here, the patients with metastatic hormone-sensitive prostate cancer with ECOG PS 1 or 0, and the patients who were being newly treated for this disease were introduced to either ADT and docetaxel with a placebo or ADT with docetaxel and darolutamide 600 milligram twice a day. It was 1:1 randomization, and the sample size was huge. It was 1,305 patients were included in the study. And the primary endpoint of this study was overall survival, and the secondary endpoints were time to castration-resistant prostate cancer, time to pain progression, which is of course very important because this translates into the quality of life. And it also had some other secondary endpoints in form of time to initiation of subsequent anti-neoplastic therapy or time to worsening of physical symptoms. And also they have measured the safety through this trial. In this trial, as also was done in the charted in the PEACE-1 protocol, that they have used docetaxel for 6 cycles. 87% of the patients received all the 6 cycles of docetaxel. That proved that adding darolutamide didn't add that much adverse reaction to discontinue the treatment in the midway of their journey. The results were pretty impressive. In overall population, it was found that the hazard ratio was 0.68, hazard ratio of overall survival, of course, it was 0.68, and it was statistically very much significant. And we can see that even after 54 months of using this drug, more than 50% of the patients were actually surviving. And we can see that both in high risk and low risk patients, adding darolutamide as the third drug proved to be very effective. The hazard ratio for both of these two subgroups were statistically significant. For high risk patients, it was a bit higher. It was 0.71, but also statistically significant. And for low risk patients, it was 0.62. The secondary endpoints were also met very well. The time to progression to CRPC, which was actually the main goal of a treatment, especially with a patient of with a high volume disease, whom if we prevent the progression of CRPC would be very beneficial. In those patients, we can find that there was 64% risk of reduction to progress into CRPC, and the hazard ratio was pretty impressive. And we can see that over 54 months, more than 50% patients were surviving, did not have CRPC. Time to pain progression was also statistically significant. Darolutamide fared very well. It controlled the pain well for a very long time, and the time to first subsequent antineoplastics therapy was prolonged by a very long time, almost more than 4 years, and the hazard ratio was 0.39, being statistically highly significant. The PSA response was very deep, and it was sustained for a very long time. We can see that adding darolutamide, the hazard ratio of having a PSA progression was very impressively decreased, and we can see that in the left curve, the Kaplan-Meier curve didn't actually step down a bit. It was around in the level of 90% even after the 54 months of observation, and we can see a pretty impressive hazard ratio of 0.23. So we can see that the PSA remained low for a very long time, and it didn't show any sign of progression in most of the patient, in as high as 90% of the patients. And I think for a very long time, it wouldn't reach the median level. And the overall survival was also benefited by adding darolutamide. And we can see that after the 54 months of observation, median value was not reached. More than 50% patients were living, and the hazard ratio was 0.37. In high volume disease, we can see that undetectable PSA, that means PSA less than 0.2, was achieved in most of the patients, and it remained to be low for a very long time, as we can see that in the left side curve. Again, around more than 70% of the patients, even with the high volume disease, didn't show any PSA progression for up to almost 5 years, and the OS benefit was also statistically significant. In low volume disease also, it was very beneficial, and we can see more than 90% of the patient didn't have any PSA progression over 5 years. So to summarize, we can say patients who are able to tolerate and can accept docetaxel, we can give the triple drug regimen to these patients in form of ADT, docetaxel, and darolutamide, and it can be effective in both high volume and low volume diseases. And we can say that the patient's age is not a factor for choosing this drug, and even in the elderly patients, especially the patients who are having some cognitive decline or having a comorbid in form of Parkinsonism or some dementia, we can use darolutamide very safely, and the patient's life expectancy actually gets very much prolonged with the combination of these drugs. And the next question, which was obviously answered with the prior speech with Kaur Madam, that was will docetaxel be an obligation in near future? Of course, we can drop off docetaxel in some patients who are not that much fit, and they can be treated with darolutamide and ADT only. So to conclude, what I can say that in a fit patient, irrespective of having a high volume of or low volume disease, if they have metastatic hormone sensitive prostate cancer, the standard of care should be the triple drug regimen in form of ADT, darolutamide, and docetaxel, and it will cause less adverse reactions. It will cause most of the benefit in form of PFS or OS or PSA, progression-free survival. Thank you. Good night.
Thank you, sir. Thank you very much for your nice presentation throughout the way and connecting with the madam, the references, whatever you have used. Really, it's an insightful presentation. Thank you very much on behalf of the team Bayer Oncology. Thank you very much, sir. So, is there any question from audience, or otherwise we can go off? I think, sir, there is no further any question, so we can conclude the session, sir.
I think tonight. Thank you. Bye again.
Thank you, sir. Thank you.
Very good
Thank
night
you.
to all.
Thank you for your session. Good night.
Good.
Yeah. So I think we can conclude the session from technical team.
Okay, sir.
Yeah. Thank you. Thanks for your support.
Recording stopped. Now we are offline.
Okay.